Okay, so this is our cardiac MR lecture. Cardiac MR is a source of a lot of anxiety for people, especially those who have attended smaller community programs, because they may have never seen a cardiac MR or only seen a few cardiac MRs, and most of their exposure is from books and stuff, so it's really terrifying, and you're at a big disadvantage when it comes to larger programs that do a lot of cardiac MR. But let's be honest, cardiologists are the only ones that really do it, and that's the way it's headed. But it's still on the boards, so we still have to know it. So let's start off with some physics, just some basic sequencing here. There's three main sequences that are done with cardiac MR, and these are two of them. I'll talk about the next one in the next case. So notice that you've got dark blood in the first image, and then the second image you've got bright blood. And this is slang that's used by cardiac imagers. We've got a dark blood sequence and a bright blood sequence. Let me just stop for a second and talk about why would they design a sequence like this. The word contrast that radiologists use a lot, basically the idea is that if you want to tell one thing apart from another thing that's right next to it, it's nice if you have a dark thing next to a white thing or a white thing next to a dark thing. It's challenging when you've got one shade of gray next to another shade of gray. So you try to design sequences that make the thing that you're looking for different than the thing that it's right next to. So the dark blood sequence is a spin echo sequence, but it's not just a spin echo sequence, it's what they call a double inversion. And the reason that they did that was to make the blood dark next to the myocardium. Otherwise you'd have a white thing next to a gray thing, and that's not good contrast, right? The way that I remember this is D for dark, D for double inversion. The bright blood sequence is a gradient echo sequence. Now, where the dark blood sequence is excellent for anatomy, the bright blood sequence is good for function and velocity and flow. And usually this is the one that you'll see that's the cine loop, the SSFP, or the steady state free precession, where you can see the contractility of the heart. It runs in a loop. This is the third type of main sequence that's used in cardiac MR, and this is what's called an inversion recovery. And you may say, that sounds familiar. I know inversion recovery. So just like you can do an inversion recovery for fat, which you call stir, or an inversion recovery for CSF, which people will call flare, you can also do inversion recovery for myocardium. Now, if you remember that this interval here is referred to as the TI, or time to inversion. The short one is for stir. The myocardial time is not like set in stone like it is for fat and for CSF. It's variable from person to person. So the old school way to do this is you do a whole bunch of different samples at different inversion times. Let's say this one's 180, 200, 220, 240, 260, 280, something like that. And what you're looking for is the one that has the darkest myocardium, the one that got nulled, right? Because you want to lose signal from the thing you're trying to lose signal from. And you also want the cleanest picture possible. So for me, this one here is the darkest relative to that or that or that. And it also has the cleanest picture. So that's the one I would pick. Now, typical inversion times are between 170 and 250 seconds. I guess it's possible somebody could ask that. It's more important to know that if you have a very long inversion time, in other words, if it took you 350 milliseconds to null the myocardium, that is specific for a disease process, which is amyloid, and I'll talk about that a little bit later. And that's really the only one that does that. So having a general ballpark idea of what a normal inversion time is could be helpful if they just straight up ask it to you, or it can also be helpful for knowing the amyloid diagnosis. So the whole point of this is to get a contrast between a bright thing and a dark thing. And the bright thing is scar. Scar will enhance on delayed imaging. It doesn't enhance right away. And this is true with scar anywhere if you have some kind of fibrosis process elsewhere in the body. It will enhance on sort of a few minute delay relative to right ahead. So the mantra is bright is dead. That's what cardiac imagers will say. Basically, you're looking for scar in the cardiac wall. That's going to enhance on delayed imaging. The normal myocardium will enhance early on, but it will wash out. And there are different patterns based on different disease processes. And I'm going to go through and talk about this. You're going to see this diagram a couple of times in this lecture. Now, the other thing that I want to talk about, which I just mentioned briefly, is that there is a second sweet spot. Just like there's a sweet spot for myocardial nulling, which is between 180 and 250 milliseconds normally, there is a sweet spot for contrast timing. So when do you give when do you image after you've given the contrast? You want to image between 10 minutes and 30 minutes. So what happens if you image too early? If you image too early, you will not have washed all of your contrast out of the normal muscle, and therefore you may overestimate how large the scar is. In other words, because bright is dead, anything that you see that's bright, you're going to say that that's scar, but it may just be because the contrast hasn't washed out of had time to wash out of the muscle that's still alive. Now, the opposite is true. If you image too late, let's say more than 30 minutes, the technologist falls asleep or is really involved in their Facebooking, that you can underestimate the amount of infarct because eventually the contrast will wash out of the scar too. So in general, for looking at these patterns and understanding them, there's two flavors that things come in. They come in either ischemic or non-ischemic. Ischemic processes are going to follow a specific vascular territory. Non-ischemics are not. Ischemic processes are going to be either subendocardial or transmural, and non-ischemic is not. So let's look at our first case here. This is just an anatomy review. This is the same case that I showed in the chest module, where we've got fat deposition in a subendocardial pattern, and it's following a specific vascular distribution, that one. And if you remember, that is an LAD distribution. The orange is RCA, and the red is circumflex. This is really important to know. You can give up multiple questions if you don't know this. You could be missing cardiac questions because of this. You could be missing chest questions if you don't know this. You could be missing nukes questions if you don't know this. You have to know this diagram. All right, so let's take a look at one. So here we go. This is a inversion, right? We've nulled the myocardium, and it is what they call an LGE, or late gadolinium enhancement. And right here, we're seeing enhancing scar, and it's in a subendocardial distribution. In other words, it's the first thing you come to here, this part, subendocardial. And we mentioned that it was in a vascular distribution. They could straight up ask you what vessel was involved in that. That could be part 1, part 2 could be, is this ischemic or not? That would be easy. So obviously it's ischemic. So zooming up here, that is indeed subendocardial. Just like I said, and that's going to make this ischemic, right? It's following vascular territory and it's subendocardial. So let's talk about why that is. The wave of infarction occurs from subendocardial to transmural in that direction as it gets progressively worse. And viability is actually graded based on the degree of, or the percentage of muscle involved. So less than 25% does well with intervention. 25 to 50% might do well, and more than 50% is considered not viable. Now, the number to remember is 50. So under 50 good, over 50 bad. That's the, if you remember anything, remember that with regard to viability. Now what about this guy? Thing with the arrow on it there. What's that? And what's that mean? We see that we've got, this is an inversion sequence. We've got a short axis and a long axis here, and we're seeing that it's transmural, it's the whole way through, but then we've got this black island of stuff that's not enhancing. Well, what does that mean? This is what's called microvascular obstruction, and basically it's an area of vascular obstruction that didn't allow the contrast to get to that part. It's dead, but it didn't get contrast into it, so it didn't turn white because there's obstruction of the vessels. So this is sort of a diagram of what this is supposed to look like. You basically have these little islands of tissue that's not getting the gadolinium in an ocean of infarcted tissue. So what do you need to know about this? There's two things. One, that it occurs in an acute setting, not chronic. Eventually this is going to go away and the whole thing's going to be scar. And the second one is that it's associated with poor recovery. It's a poor prognostic sign. So the next one here, this is just a little bit of vocab, and the way that this would be shown if they were going to ask you would be in one of those dynamic cine SSFPs where it's showing the heart pumping. So normally, during systole, the myocardium will thicken, and it should thicken here, should thicken here, and it should thicken here. All the parts of the heart should thicken. See that? Just look at the normal one for me. See how it's thickening the whole way around? That's normal. Now the word hypokinesia is used when it thickens all the way around, but not as much as it should be. I think this is really hard to show because it's kind of subjective. I don't think that they'll show that, and that's why I didn't even put it down here. But if they would write it out in words, hypokinesia does contract, it just doesn't contract as much as it should. Now akinesia is going to be a segment that does not contract at all. So if we look here, this part's contracting, this part's contracting, this part's not. Watch, it stays the same. See that? So that's, you would say that this apical portion here is akinetic. That's not contracting. Now dyskinesia, it not only does it not contract correctly, it actually bulges in the opposite direction. So it's like retarded, it's going backwards. So that's dyskinesia. Dyskinesia bulges in the opposite direction. Akinesia doesn't move at all. Hypokinesia moves normally, but less than it should. All right. So here's another sequela of ischemia. We've got red and orange, and what I'm showing here are two different types of aneurysms. So the one on the red is the one that you see more commonly. You see this one fairly often. The one on the orange you don't see as much. So this is a true ventricular aneurysm, and this is a false ventricular aneurysm. And if you remember just from med school, basic med school, that a pseudoaneurysm or false aneurysm does not contain all the layers of the vessel, whereas a true aneurysm does, right? Same thing holds true here. And there are a few other differences that people use to tell them apart. One is that the true aneurysm mouth is typically wider than the body. In other words, this part here wider than this part here, This part here skinny, this part here wide. The location, these are usually anterior. These are usually posterior lateral. The myocardium intact versus not being intact. And this is another one that's very important, is that a true aneurysm takes months to actually show up because it's a process of remodeling. A false or pseudoaneurysm occurs almost immediately after an MI, and it's the same general time period where you're at risk for a myocardial rupture after an MI. And that makes sense, right? Because you can imagine that a pseudoaneurysm would rupture more easily than a true aneurysm that still has those layers of thick muscle and scar. All right, moving on. We've got another late gadolinium enhancement study. And this time it sort of looks like an Oreo cookie, right? We've got black, white, black with the enhancing part here in the middle. That is not vascular, right? Because remember I said that the wave of ischemia has to occur in this direction. You can't have ischemia if you don't have subendocardial involvement. So we're dealing with non-ischemic heart disease here. This is myocarditis. So it's mid-wall or subendocardial on the opposite. Epicardial or mid-wall, not subendocardial. It's going to look, if they show it to you, I think that it will look most likely like this. It favors the lateral free wall, and myocarditis is most often due to a virus, Coxsackie virus, if you remember that from med school. So I've got a way to remember the pattern for myocarditis, which is, remember that I said that it looks like an Oreo cookie, where it's black with the cream in the filling and then black on the outside, and sort of on the outside wall there. So the person who I know that likes cookies is this guy, and cookie monster for myocarditis, so MM. That's the way that I used to remember that. Okay, here we go. So a couple of hints on this one. First of all, notice that the blood is darker than the myocardium. That's unique to this. Nothing else has that, right? Blood is darker than the myocardium. You don't see that on anything else. Also notice that I've provided you with this inversion time, which is very long, right? We said normally it's around 200 or so. And this is our enhancement post-contrast imaging here, and we're seeing that there's nearly circumferential enhancement here, and if we went up and down a few cuts, it would look more even like that. So this is amyloid. It's usually secondary. What can be either primary or secondary amyloid that can involve the heart. The classic findings are that it's circumferential subendocardial involvements, not endovascular distribution, and that the blood pool is darker than the myocardium, or they may tell you that it was very difficult to null the myocardium, or they may provide you with a terminal or a inversion time that's very long. Those are all your hints. Okay, the next one here is also got a very characteristic finding, which is this biventricular thrombus. Now, this is another sequence that I haven't talked about, which is this first pass perfusion. This is a post-contrast imaging that's done early on, sort of like you would think about doing contrast with CT, where you give contrast and you see what enhances early on. Remember that we don't do that when we're looking for scar, because myocardium enhances normally, and you have to be able to differentiate that from scar. So what causes biventricular thrombus? Classically, there's one thing that does it. It's eosinophilic cardiomyopathy, or Loeffler's. And it's basically eosinophil infiltration, which causes this fibrosis of the myocardium. It's a form of restrictive cardiomyopathy, and bilateral ventricular thrombus is the only thing you need to know about it. Okay, so this is an entity that is classically shown with a cine because it would be super difficult to show this with a still image. And what I'm attempting to show here is you'll notice that the ventricular septum is going to bounce. All right, so watch it bounce here. See that? Bounce, 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 bounce. Okay, so that's a very classic look. And this is constrictive pericarditis. And basically what's happening is you've got a calcified pericardium, which is essentially making the ventricles linked. So there's a set volume that can be within both ventricles total. So as one empties a little bit, it allows the other one to fill a little bit. And this is called ventricular interdependence. And you end up getting this septum bulging towards one side as one side fills, and then back the other way as the pressure gradient reverses. And that will be changing with respiration. So some buzzwords here: sigmoidization, diastolic bounce, ventricular interdependence. These are all basically referring to the septum moving back and forth. And it's all occurring secondary to this physiology where you've got a calcified pericardium. Now, why do you have a calcified pericardium? Historically, and probably on the test, it'll be secondary to TB. In the real world, it's usually secondary to a cabbage. So let's review constrictive and restrictive pericarditis, because these two words sound the same, and a lot of people think that they mean the same thing. So the constrictive pericarditis is from TB or the prior cabbage. Restrictive pericarditis are like amyloid or the eosinophilic case that I showed. This constrictive is a pericardial process. You remember that if they want to show this to you on CT or on a plain film, they're going to show you a calcified pericardium or a very thick pericardium. The restrictive pericarditis are a myocardial process where you've got infiltration into the muscle either by amyloid or some weird eosinophil thing going on. Okay, now we're going to just go through a couple of cases that are associated with sudden cardiac death in younger people. So our first one here, we've got diastole and systole. Now this could be shown in a moving clip, and the point of this is to show you how thick this apical segment here in this part of the septum is. And here's a late gadolinium enhancement, and this is demonstrating some patchy enhancement with delayed imaging. So this is hypertrophic cardiomyopathy. It's basically a defect in the cardiac sarcomere, which causes this really bulky muscle that doesn't contract normally. Now, what do you need to know about it? What it looks like: thickened muscle. It can also look like this, where you just have the septum thickened, almost like it looks like a tumor. Enhancement is typically patchy if you have it, and it's associated with poor prognosis when you do have that patchy enhancement. And it's also associated with a thing called SAM. Now, what is SAM? Here's a 3-chamber view, just to orient you: aorta, left atrium, left ventricle. And we'll review the anatomy real quick. This is your mitral valve. Mitral valve has 2 leaves, not like a tricuspid valve, which has 3. The mitral valve has 2 cusps. It has an anterior medial and a posterior lateral. So the one that we care about is going to be this one here. This is the anterior medial one. So with systole, the anterior medial valve, if it gets sucked up into the left ventricular outflow, that is bad. It's associated with bad prognosis, and this is a thing that's seen with hypertrophic cardiomyopathy, and cardiologists will refer to this as systolic anterior motion of the mitral valve, anterior medial leaflet, or SAM. So something like that. So here's an actual case of it happening. So you can see that right there. That's what I'm talking about. So we were here, and with systole, you can notice, you see how this is contracted here, that it's getting sucked up into that, and this is narrowing this outflow track here. So let's review these. This is very high yield. So these two here, we talked about how we're following a vascular distribution, and we are occurring in this direction, subendocardial to transmural. All this is more severe. Viability is depending on the percentage that it involves. 50% is that key number that you need to remember where it's no longer viable. Amyloid is also subendocardial, but it's circumferential all the way around. Amyloid is going to have that, the blood is going to be dark, and it's going to have that prolonged inversion time around 300 or 350, where it's normally around 180 or 200. Hypertrophic cardiomyopathy will have this patchy sort of cloud-like enhancement. When it does have it, it doesn't have to have it. When it does, it's associated with a poor prognosis. It'll favor the septum. Myocarditis is going to be classically in the middle, look like that, look like an Oreo cookie, and it favors the lateral free wall. And sarcoid can look like that also. That's a case that I didn't show. And like sarcoid does, it can do a lot of different things. It can involve the septum or the lateral free wall. All right, so moving back on to some other things that cause sudden cardiac death. I've got a picture here of end diastole and end systole. And you might think that I just copied and pasted the same picture twice, which I didn't. This is actually at different time intervals. So what you're seeing is this increased trabeculation, and it's thickened, and it's not contracting correctly. So this is what they call left ventricular noncompaction. It can cause sudden cardiac death at an early age. That's basically what it looks like. That has to be the way it's shown. There is a ratio between compacted and non-compacted, but I would say it's not going to be an eye test. If it's shown to you, it's going to be very obvious that it's not changing. So just remember, non-compaction is not compacting. It doesn't change. All right, next case here is a CT case, although it could be shown with MR also. I chose CT because I thought that this would be easier. I'll point something out here. So this density right here is fat, right? And you'll notice that that is the same density that's in this right ventricular wall. So there's a huge fatty infiltration in this right ventricular wall. And as we go down later, you're seeing all this excessive trabeculation in the right ventricle as well. So this is arrhythmogenic right ventricular cardiomyopathy. It's basically fatty degeneration in the right ventricle. Notice the left ventricle is normal. Notice the right ventricle is dilated. And I just want to point out that a sneaky way to show this would be to use cardiac MR and use a fat-saturated sequence to demonstrate that there's fat dropout within the wall. And you'd have to think to yourself, what has fat in the wall? Of the right ventricle, this has fat in the wall of the right ventricle. All right, so another CT case. And we've got a mass here, rounded mass. So what's the next step? I guess your differential is what? Your differential is going to be thrombus versus tumor. How do you tell the difference? You can get a cardiac MR, and you can use an contrast to see if it enhances. The thrombus will not enhance, the tumor will. So This is our post-contrast image here. We're seeing that it is indeed enhancing. So we know that's a mass. It's in the atrium. It's in an adult. So this is an atrial myxoma. It's the most common primary tumor of the heart. Mets obviously are much more common. Mets typically involve the pericardium. They do enhance. They can prolapse into the mitral valve if they're on the left side and cause sudden death. They will throw emboli because they're messing with the normal dynamic blood flow. This is opposed to, so remember this is an adult. If you had a kid and you had a mass in the left ventricle like this here, you might say that that would be a rhabdomyoma, and that's seen in children, and typically children with tubular sclerosis. This can occur, so atrial myxomas, adults in the atrium, rhabdomyomas, left ventricle of a kid with tubular sclerosis. All right, so this concludes this cardiac MR talk. I'm going to do one more talk on the heart, which is going to be just some review of some nuclear medicine, and that'll be coming up next.